So at what point do we test for PD-L1? I usually test early, and you can do this as part of a genomics panel. There are certain platforms, for instance, like Foundation Medicine, that automatically tests for PD-L1. Certainly, while I mentioned earlier that we do not necessarily need to test PD-L1 when using second-line therapy and beyond for checkpoint inhibitors, for first-line therapy for metastatic urothelial cancer, and especially those who are cisplatin ineligible, that is where the utility of the PD-L1 testing is. But for those who are cisplatin eligible, chemotherapy remains the standard of care. And in fact, even those who are ineligible, who are otherwise carboplatin eligible, chemotherapy is still and remains to be the standard of care. Now, these are, of course, areas of contention. Some people would test only at the time when there are no other options, but for the most part, I believe testing early would be the way to go so that we have that information early enough on hand. Now, which test do we use to determine PD-L1 status? So this, I think, is also highly dependent on each institution, your practice, as well as the comfort level, even for the pathologist. So essentially, it's really dealer's choice. There are also certain FDA-approved tests that accompany, the use of certain drugs. So, for instance, for atezolizumab, it is recommended to use the Ventana SP142 assay, and their definition of positive also differs. So, for instance, for the Ventana SP142 assay, the PD-L1 expression of more than or equal to 5% for the immune cell is considered positive. And for instance, for pembrolizumab, they use a different assay. They use the 22C3 antibody, and they're looking for the combined positive score of more than 10. So it really varies across platforms, and there has been no real great standardization of all these assays. So I would say whatever patients or really physicians and institutions are comfortable with, and whatever drug they mean to use. So for instance, for avelumab in the Javelin trial, they used SP263 assay.
So for our advanced urothelial cancer patients, we are getting next generation sequencing because about 10% of patients may exhibit FGFR3 mutations, for which we have an available drug called erdafitinib. And PD-L1 testing is also routinely done as a part of these tests to guide therapy for patients who cannot get platinums as first-line therapy. As far as molecular subtyping goes, that's still an active area of research.